Okay, we'll start today's meeting. Just to highlight, we are recording today's event and it will be posted on the Explorathon Facebook page at a later date. Please, if you are an audience member, keep your camera and microphone turned off unless you're asking a question. My name is Rachel Elliott and I'm the Explorathon Project Officer, and I'm going to hand over to Leslie Anderson, who's the moderator for today's event. So Leslie, over to you.
Thank you, Rachel. And I just wanted to take this opportunity to thank the people who have attended today. It looks like we've got quite a good number. And with recording of the session, this will also be available to a much wider audience. As Rachel has said, the conversation today is going to be recorded, so please keep your cameras and microphones off unless you're asking a question at the end. You can also put any questions as we go through the presentations that you might have in the chat, and I will keep an eye on those as we come to the end and open up for question and answer session. I also want to take this opportunity just to thank our speakers today, Dr. Gerald Lipp, who is... I'm getting some feedback, apologies. Dr. Gerald Lipp, who is the Clinical Director of the North East Breast Screening Programme in NHS Grampian. Dee Deenan, who works with Caron, and we'll hear more about the technology behind the breast screening. And Dr. Clarissa de Vries, who is a research fellow at the University of Aberdeen and has been doing some fantastic work around acceptability of AI in breast screening with breast cancer patients. So I'm sure they'll fill you all in more with their presentation today. And I'd like to take this opportunity to pass over to Gerald.
That's great. Thank you very much, Leslie, for the introduction. And I'm just going to get my share slides up now and bring you through just a basic introduction of what we do in breast screening in Scotland before I hand over to Dee to just talk about the sexy AI stuff. And then Clarissa to talk about our patient engagement and what we've been doing in the iCAIRD program as well. So the screen is just slowly loading up. I think it'll appear in the next 30 seconds, hopefully. Yeah, I'm getting it there. So this is Explorathon. I'm the Director of Breast Screening in North East of Scotland Breast Screening Service. And I think we just go back to basics first and just talk about breast screening as well. And Cancer Research UK, 2 million people go for breast screening every year in the UK. In Scotland, it's about 200,000 women a year who attend throughout the whole of Scotland in our population of 5 million people. It's the most common cancer among women in the UK. 1 in 8 women will get cancer sometime in their lifetime. But what's really important is that survival is really going up and up and up. There's new therapies, earlier detection with screening, and lots of methods that we're using now to help treat cancer almost to a personalized level where we can get hormone receptors and various tablets as well. So it's a positive thing. Get yourself checked if you are under 50 or above 70 and come for screening. That slide hasn't loaded. Let's see. Let's go back to the previous slide again. Okay, well, never mind. The previous slide was basically a map of the north of Scotland, northeast of Scotland, showing our patch. In Aberdeen Screening Centre, we cover the static, which is the screening centre itself, and we cover 18 miles from there. And then we have 2 mobiles that we station over a 3-year program across the whole of the northeast of Scotland, going all the way up to Shetland, Orkney as well, where our mammographers take mammograms and they are sent back to the centre, and we analyze them in the centre. So that's about 80 mammograms, or about 25,000 women invited a year, 20,000 attend, that we analyze in the centre through the screening service. An important thing, a public health message here is that screening is for asymptomatic disease. So if you have a lump or you feel a lump, go to your GP and get it checked out, because we're aiming to find the small cancers in screening before they can be felt by you. So it's an asymptomatic screening service. As with everything, COVID has slowed us down. We're about 3 or 4 months behind in a 3-year cycle where we move to each part of the country. But we're working evenings and weekends And really, we'll aim to catch up as soon as we can. And here are the numbers. 100 women between 50 to 70 years old have breast screening. A few are brought back for more tests. And of those few, again, we find one that's 1 in 7 in 1,000. It's a big headline figure numbers. And those mammograms are a bit like this. You kind of have to read 1,000 mammograms to find 7 cancers. So imagine reading this all the time. And I'm sure you're all looking and trying to find Wally in the picture now. And the fast ones would have found it already. And experienced radiologists like myself would have seen 10,000 Wally pictures, and we can pick him out straight away. In fact, he's near the middle of the screen, just to the left, if you're all looking quite closely there. So that's how it works in breast screening. We look at cancers, we look at mammograms, and we get trained to detect cancers. And Dee will speak about this later in terms of the AI. In a lifetime of training, I probably would have been trained on 5,000 mammograms a year to start with. Maybe in my lifetime, I will see 100,000 mammograms, which is still quite a lot of mammograms if you think about it. And I'll let Dee speak about how much the AI has trained. So here's a nice example of mammogram. You have one set of mammograms that takes 4 pictures. You have your side-by-side view, which is why it says MLO on the top of the screen there. And that squeezes the breast side by side to get a picture there between the detector and the plate. And then you have something called a CC view, which is another set of 2 pictures of the left and right breast, where you have a little squeeze from the top to bottom. And in this picture, just checking to see if, yep, it does show, sorry. So in this picture here, this is a rather obvious breast cancer to a professional, where you can see that there's a big white mass at the top of the picture, and there's nothing on the other side of the picture. This is a gimme. This is something that you should, most women should be able to feel in their breasts. Some people are a bit afraid of that lump and they don't go. And by the time they get to us in screening, this is considered too late, quite a late cancer at presentation. Another example that you can see here is if you're looking, comparing left and right, there's a bit more white stuff on the left side of the picture, right side on the screen as you're looking, circled in red there. So these are pretty straightforward breast cancers that an experienced radiologist will get. But then we can go a little bit more interesting and a bit more subtle. If you're looking at this screen, you can go, wow, what's over here? And that's the difference. Every breast has a different picture. It's almost like a fingerprint. And if I look at an image from a breast from now and 3 years ago, I can pretty much say this is the same lady when I look at it on the screening for myself. The breasts themselves are composed of fatty tissue, which is the gray stuff, and then connective tissue, which is the lines you see across there, and the white stuff, which is glandular tissue. And cancers grow in the white stuff. So you look at the white stuff here on this screen, and you see that little round circle just there. And that's a little tiny cancer that's about 7 millimeters in size. That's the kind of stuff we want to be going for because of something called lead time bias. If you can catch a cancer early before it becomes big, that would be good because you can catch it before it spreads to the rest of the body. And it much improves the morbidity and mortality of the women that we serve in the Northeast. Another example here, let you guys have a look around and spot. And it's over at the bottom on the left side of the screen as you're looking there. So these are subtle things sometimes, and they, in retrospect, humans do miss them. And I'm sure an AI will miss some as well. But the combination of an AI and human reading together, we believe will give the best results in finding as many cancers as we can in this group. Again, here, this is a bit more subtle, and it's just up at the top. If you look up, hiding where the muscle is. So the white stuff is the muscle underneath and the breast there, the pectoral muscle. And another example here is to illustrate the point that not all cancers can be seen on mammography. Mammography is only 90% effective. So there are bits that an AI and a human would not be expected to find. There's a 5 centimeter mass in this lady's breast. And I don't think anyone, even in retrospect, would see it. We would call this an occult tumor. And it's just over there. And that's how difficult it is. Another factor is dense breast tissue. So in this example here, as I said, the white stuff is glandular tissue, the lines are connective tissue, and the gray stuff is fatty tissue. This lady has very dense breasts. And in this kind of scenario there, you're looking for white on white, and it'd be hard to see anything on the mammogram. But she also has a very subtle cancer over there, which we managed to pick up. So let's see if the AI can pick that up as well. I'm going to stop presenting here and introduce Dee Deneen. She's our partner in the iCAIRD. She's a member of iCAIRD Medical Technologies, which is our partner in the iCAIRD consortium, where we're trying to use AI to see if we can read as well as a human reader. And we've been using anonymized Northeast of Scotland data in the consortium with these images and applying the iCAIRD algorithm. And we would hope to report that pretty soon, maybe at a future meeting. Dee, I'll pass over to you.
Thank you, Gerald. I'll just share my screen now too. Oh, sorry, 1 second. Great. Okay, thank you, Gerald, for that whistle-stop tour of breast cancer screening and mammography interpretation. So my name is Dee. I'm Senior Partnerships Manager at iCAIRD Medical Technologies, and I've been working with Clarissa and Gerald on this project. So Gerald's given us a bit of an introduction to screening, and I wanted to just touch a little bit more on what happens once a lady leaves her screening appointment and the images are acquired, and we move into the analysis stage that Gerald was demonstrating to us. So screening is double read, meaning two highly trained interpreters of mammograms, such as Gerald, look at the case, which is all 4 screening images, and make a decision of whether or not that lady ought to come back for follow-up assessment. If they agree that she should come back for follow-up assessment, that's a decision made and she'll be invited to an assessment clinic. If they agree she doesn't need to come, then via her GP, she'll receive a letter to come back for screening in 3 years' time in the UK. If reader 1 and reader 2 disagree, then the downstream workflow is that it goes to a third reader arbitrator or group of readers who will make that ultimate decision of whether she should come back for further assessment or not. So at iCAIRD, our AI solution is called MIA, Mammography Intelligent Assessment. And we've designed MIA to fit into that double reading workflow as an independent reader. And it's a really, really nice use case for 2 reasons. One, that the downstream workflow doesn't change at all. So if reader 1 and MIA were to agree, that would be the decision made. And if they were to disagree, then a human arbitrator or group of arbitrators would make that ultimate callback decision. So there's always a human in the loop. And the other reason it's really nice is because you have really good outcome data in screening. So I imagine there the examples Gerald was showing us, lots of those will have biopsy proof that there is in fact a cancer present. Or similarly, there's nice longitudinal negative data. So if a screen is called negative and 3 years later the lady comes and her screen is called negative again, you can be fairly confident that that original screen was in fact negative and didn't have any signs of cancer on it. But as Gerald mentioned, it's really the combination of the AI and the human reader that we find so exciting about the potential here. So what is MIA? At very, very, very high level, deep learning explanation. But if you feed models tons and tons and tons of images that are really well labeled, either recall, no recall, or cancer, no cancer, the models can learn for themselves the features of these images, such that when they're presented with a new image that they've never seen before, they can make that decision themselves, a recall or no recall. And so ultimately, that's what MIA does in the screening workflow, just provides a recall, no recall decision that feeds into the workflow. If it's being interpreted further down the work stream, maybe by operator, then it can give an image indication of where it found a suspicion and an explanatory region of interest, which is this kind of pink marking here, or similar to the kind of, you'd expect it to be similar to the kind of red circles Gerald was drawing around his mammograms. So yeah, quite simple in presentation or user interface, really. We just wanted to make that case-wise recall decision exactly as the human reader does, and then give a kind of indication of where there's a suspicion if it suggests recall. So we've worked with partners all over the world to train MIA on over 3 million images. It's really important for us that we get a diverse selection of partners so that we can be fairly confident that MIA has seen lots of different demographics and lots of different populations. our kind of inaugural partner was the public breast screening service in Hungary, which is Mama Clinica, shown here. We've since worked with partners in the UK NHS, across Europe, and we're working with partners in the US on our FDA submission as well. So I wanted to touch a little bit on evidence generation so far. So MIA gained a CE mark back in 2018 based on some early clinical trials we did with the Hungarian partner. But I wanted to talk a little bit more about some projects I've been involved in more recently. First of all is an abstract presentation that we're giving next week at the Radiological Society of North America. Now, this was on an analysis of 40,000 cases that we have internally at iCAIRD that were collected from various UK breast screening partners, but not used in the development or training of the models. So these were internally withheld specifically for the purposes of testing. There's over 40,000 cases in that kind of bucket. And what we did was we modeled the double reader screening program using MIA as the second reader. So we used MIA's recall suggestion and the historical first reader's recall suggestion, and we're able to simulate, okay, in that scenario, how many cases would go through to arbitration and be read by the second reader. So that's being presented next week, and we received some really nice feedback that it was amongst the meeting's most highly rated abstract. And if anyone who's ever been to RSNA in Chicago will appreciate the scale of that, and we were pretty pleased with that. Subsequent to that, we have done a externally kind of validated clinical study with a contract research organization doing all of the analyses. So this is on over 250,000 cases that have never been kind of brought internally to iCAIRD for training or testing purposes. They've remained on site at our clinical partners, and we analysed all of those cases with MIA, and the results are currently being reviewed by our CRO and generated by the CRO. So that will go into a number of endpoints relevant to screening programs. So sensitivity, specificity, there'll be some ROC curves which you'd expect to see in kind of machine learning analyses, and together with the simulation that I mentioned on much larger scale. So we're really looking forward to disseminating those results shortly. And also very recently, we've been invited by NHSX and Public Health England to take part in the kind of process definition of what would a validation exercise look like if say Public Health England were to run entirely independent validations of AI products like ours, that they would then say, okay, we believe this is good enough for you to use in your breast screening services, because breast screening is public health initiative. So in England, Public Health England oversee that. In Scotland, it's National Services Scotland, I believe, but above them sits the UK NSC, which is the National Screening Committee that review all of this evidence and make those recommendations. So we were involved with an exercise with them where they curated a test set of 26,000 cases, and we handed over our solution for them to do some testing on that test set, which was cool because they chose the operating points that they thought would be most effective, and they chose the endpoints, and I think everyone learned a lot from that exercise. So watch this space, but it also sets the scene nicely for the work we're doing in Aberdeen. So what are we up to in Aberdeen? Clarissa's going to introduce iCAIRD for us, but essentially we're doing a retrospective assessment of the MIA technology on the historic cases from the North East Scotland breast screening programme. So as part of iCAIRD, the Grampian Safe Haven have a platform developed for machine learning research called SHAPE. And all of the historic cases from the North East Scotland breast screening programme have been very robustly pseudo-anonymised or de-identified and transferred onto this platform. This image here is an example of how the data is structured within our workspace on that platform. And we can now access the platform and upload some models to do some retrospective testing on the North East Scotland population. And that's really cool because, again, we've not trained or developed MIA on screening cases from North East Scotland. So it's a nice independent test set for us to look into. Then Gerald and colleagues will interpret the results and see, is the performance of the AI solution acceptable within the range of performance that they see from their human readers, and compared to various other bits of research that Gerald and Clarissa have been doing on this data. And if we pass those kind of early benchmarks, then we'll be looking to move into a more real world evaluation where we simulate various scenarios in the workflow with Mia kind of plugged into the real world systems. So that's what we're up to in Aberdeen. Some learnings from across all of our projects. These aren't trivial projects and partnerships to work on, and each one is different, and we learn a ton every time. I think two main things I wanted to point out here is it's not just about building models or algorithms. You have to really find a clinical need that you're solving for. And I think in this case, within the double red screening workflow, we've got a really nice kind of product fit there because as Gerald mentioned, it's really hard to find those small cancers. He's spent how many hundreds of thousands of mammograms Gerald's read in his life. I'm sure he's got plenty of other things to be doing along the patient pathway with the follow-up clinics, etc. So, and there's a national workforce crisis for breast radiologists. So we're really trying to solve for that need. And I think one kind of hard thing or barrier that I'd pull out from our work in the Northeast and in iCAIRD is just how important it is to make sure that you've gone through every governance pathway and approval pathway, and that everybody who needs to know about your project and know what you're working on is really well informed. And we take that very seriously as a project in iCAIRD. And I think we've done a really nice job as a team of making sure that everybody is well informed and happy for us to go ahead with this kind of research. So one such governance pathway is the Public Benefit and Privacy Panel, PBPP, which some of you may be familiar with. And they're really keen that throughout our project going forward, we do a lot of public engagement and patient engagement and tell people about what we're up to and involve people as much as possible. So you can see a little working group. There might be some familiar faces on there for us brainstorming how best we can do this. Gerald is no stranger to the local press and hopefully national press talking about our project. And also this here is a box that is in Gerald's breast screening clinic, where over the last few weeks and months, we've been collecting hundreds of responses to a survey that Clarissa and Gerald have developed to hear about public attitudes to using AI in breast screening. At which point I will hand over to Clarissa, who's going to tell us a bit more about the results of some of that work. So thank you very much.
Hello, can you all see and hear me and see the slides?
Yes, thank you, Clarissa.
Yeah. Okay, good. Well, I'm Clarissa and I'm a researcher at the University of Aberdeen working on the iCAIRD project. Oh, sorry. iCAIRD stands for the Industrial Centre for Artificial Intelligence Research in Digital Diagnostics, and is a pan-Scotland collaboration of industry, NHS and university partner. iCAIRD aims to support the creation, the testing and the implementation of artificial intelligence tools for use in healthcare. As part of this program, a secure environment called SHAPE has been created in which companies can access anonymized NHS health data. So this allows companies such as iCAIRD to develop and test their AI algorithms with this data. And the work that we're doing in NHS Grampian as part of iCAIRD is focused on the use of AI for breast cancer screening. Breast cancer is one of the leading causes of death from cancer in women, and early detection considerably improves treatment outcomes. As already discussed by Gerald and Dee, the NHS has implemented breast screening programs for women between 50 and 70 years old. Here, as part of this double reading, 2 experts examine each mammogram. Sorry?
Apologies, Clarissa, just checking, we're still on your first slide of your PowerPoint presentation. I'm not sure if you've moved on.
No, that is correct.
Okay, apologies.
No worries. So as part of double screening of we have 2 experts examining each mammogram, and if the 2 experts disagree on whether a woman should be invited back for additional examinations, a 3rd expert makes this decision. And through these additional exams, it is determined whether a woman has breast cancer. And as part of the iCAIRD program, we are currently testing the AI system in NHS Grampian using anonymized patient data in the secure shape environment. This patient data is historical, as Dee already mentioned. This means that the patients have already been through screening and we already know whether they are diagnosed with breast cancer. So the testing of MIA does not influence patient care, and future plans include testing MIA with Scotland-wide data. We have also created a short questionnaire to find out what women who attend for routine breast screening in NHS Grampian think about the use of AI in breast screening. They represented our questionnaire, which can be completed in a few minutes. The questionnaire presents several potential options for the use of AI in breast screening. So as mentioned earlier, currently 2 experts look at each mammogram. So a first scenario could be that of the 2 experts, 1 expert is replaced by an AI. They both give their opinions, and if they disagree, a third human expert makes the final clinical decision. A second scenario was that the AI replaces all human experts. And so no human sees any mammograms, it's all determined by the AI. A third scenario was that the AI examines all mammograms, and if the AI is unsure if there's a cancer or if it's a difficult image, it would be sent to a human expert for review. And a fourth scenario was that all human experts have access to an AI to help them reach a decision. So you would still have 2 human experts reading the images and a third reader arbitrating in case there's a disagreement, but they can all use AI. And now for the results is we in total have 187 women who filled out this questionnaire. And the options that were on average the women approved of were options that combined the AI with a human reader. So the most favorite options, if we're looking at the blue and the orange bars, are, so the blue one is where 1 human is replaced by an AI and you still have a human reader. And the orange one is where all specialists have access to AI to help make their decision. And in general, women approved of these options on average. If we're looking at the green bar where the AI examines all mammograms, but if it's unsure, it will send to a human reader. Women also on average agreed with that, but to a lesser extent than the other 2 options. And the most divided, the women were the most divided on the option where there was only AI to examine the mammograms, where looking at the red bars, you can see that quite a number of women objected and strongly objected. There were also quite a few that were approved, but on average, this would be more neutral and actually negative to neutral. And there was also a 5th question. Would your opinion change if the use of an AI would lead to faster screening results? And most women would say that if it would lead to fast screening results, they would be more likely to approve of the 4 scenarios in the questionnaire. So looking at the age distribution, most women who responded to the questionnaire were between 55 and 59 years old. And on average, their understanding of AI, most women would rate that as average, because one of the questions we asked was, what is your understanding of AI? And interestingly, we also looked at the relationship between self-reported understanding of AI and how much they approved or disapproved of the various scenarios. And women who felt that they had a better understanding of AI also approved of the scenarios more than women who felt that they didn't have a good understanding of AI. So this suggests that more public engagement would improve a women's acceptance of AI in breast cancer screening. So that's a short overview of the work we've been doing as part of iCAIRD in NHS Grampian, and I'd just like to thank you all for listening.
Thank you, Clarissa. It's been really interesting and fascinating to hear from yourself, from Dr. Lip, and also from Dee Deenan. It's actually really nice seeing this collaboration between the NHS, industry, and the university, and hearing from the three different groups. It's been fascinating to see the differences and where everybody's coming from. I suppose a different standing point, but where the platform that you're looking at developing and integrating into clinical practice can really make a huge difference for women being diagnosed with breast cancer. Gerald, is there anything else that's being covered, or will I open the floor to questions?
Oh, please open the floor. We're happy to take
open the floor to questions. So if anyone has any questions, you can either put them in the chat and I can answer them on your behalf, or if you would like to ask a question, if you can click on the hand at the top of your Teams screen and put up your hand. I did see one come up and then it's disappeared on me. Maybe while I'm waiting for people to draw their thoughts together, I was very impressed by the work that is done through the screening programme, and I have taught screening to medical students for many years, and we bring them to the screening unit and flash up in front of them the images for them to be able to detect the breast cancers, and was always amazed at how slow it took me and the students. And it was interesting, Gerald, just saying how long you had the slides up there. I was able to detect most of the cancers, which was good. I should know that after having taught this for a long time. But really the speed at which the radiologists have to look at this, how quick or how long do you have to look at each image to make a decision?
So the expectation for most radiologists, we don't give hard and fast numbers, but we give you a session for reporting. In a week, we'll go only 4 hours to report. You should do about 120 mammograms during that time. There have been eye tracking studies where they have tracked radiologists' eyes versus trainees and consultants and members of the public and other doctors. And the eye tracking studies show that there's a significant speed in which the experts or trained people in, I think it was 0.12 microseconds, can draw their eyes straight to the area of abnormality. So that was quite interesting to see how fast that was. And I'm sure AI will be just as fast in using the whole computer algorithm and track and go across to that area of interest as well. It's different from CAD in the past. So there's computer-aided detection. And CAD in the past used to have very poor specificity because it had circles all over the breast on the mammogram, whereas AI nowadays has used the neural networks to just get to that one spot of most suspicion. And that's been really good to see in this research so far.
Excellent. Dee, do you want to just follow on from that with the sort of speed at which the MIA platform can review images?
Yeah, I was just, as you were speaking, trying to pull up the estimate that I had for how long it would take us to analyse those 26,000 cases in the example project that I mentioned. Oh, I'm trying to find it. If you give me a minute, I'll raise my hand when I've got it. But basically, it depends on the compute power that you can throw at what you're doing as well. But it's pretty rapid. I'll try and come up with some numbers.
That's great, thank you. I have a question here just from Rachel Elliott, which is, have you done research with other clinicians involved in cancer diagnosis and treatment, like oncologists, about what they think about the use of AI here? Oh, you're on mute, Gerald.
I should wear the t-shirt, you know, we have the paddle from the Strictly I'm on mute kind of thing. But yes, we have done that research, and Brian Morrissey, who was one of our grads, has started that a while ago, looking for opinions of clinicians. So that's in process, and generally it's positive because they recognize that anything that can help release breast radiologists into clinics a bit reduced from reading, but maintaining the quality and the cancer detection rate is always going to be a benefit. Surgeons themselves have moved into other areas like radiofrequency tags, robotic surgery. So new technology is nothing new, nothing unusual for them, and they're positive to that as well.
It was lovely to see as well from Clarissa's work that the women are also really receptive of the use of AI in screening as well. Alison, you have your hand raised.
Yes, I just wanted to ask probably a really predictable question about reproducibility. So we always assume that the reproducibility is lower for the human observers because their performance is affected by tiredness, time of day, etc., and that it's perfect for the AI algorithm. Is that always the case? Is reproducibility for the AI method always 100%?
I could go into that first, and then I'll let Dee take the second answer for that. And that's coming to the discussions now as AI comes closer and closer to real life implementation, that Public Health England, National Service Scotland are looking at this safeguarding, governance, reproducibility, and safety. And test sets, such as the North East of Scotland test set, which is established, could be the basis for which you can keep repeat testing or quality testing your AI. As new versions of AIs come, you want to retest and make sure that it's picking up what it was picking up and picking up more, and that you don't get a sort of drift or bias in the process. Dee, did you want to come in on reproducibility as well?
Yeah, thanks, Alison. It's a really good question. I mean, I think the short answer is that you would want it to be 100% reproducible every time for various reasons, not least because you want to trust what it's saying. But the kind of longer, interesting answer is that the model itself outputs a number between 0 and 1, and that can be a kind of continuous number. And whether it says recall or no recall depends on the threshold that you set that you want that model to operate at. So you can change the threshold and then your answer will change depending on what you want the model to do. But I think when we're talking about deploying the product to do the independent reader role in the workflow, it would very much be a set threshold that then you would anticipate that every time it sees the same case, it would make the same output decision. But the kind of plumbing behind the scenes is you can choose the threshold that you want it to operate at.
Great, thank you.
And I suppose just Dee, to bring you back in relation to that. So from a machine learning perspective, because that's, I suppose, different than just utilizing artificial intelligence coding to run through, is the platform, does it continue to learn? Or once you've done the training data sets that you've worked on up to this point, is it then static? And so that stays, then the algorithm stays whenever it's deployed into clinical practice.
Yeah, that's another really good question. And the answer for that kind of sits with regulatory processes at the moment. So what we do is we would run a large scale clinical study. Those results would get put into the technical file for the product. And then that product with those frozen models gets, say, the CE mark. And then the current kind of landscape is that your CE mark product is deployed and that is completely frozen and wouldn't learn on the job. Then if back at kind of HQ, you're continuing to train the models, currently you want to kind of update the CE mark periodically. I think we're probably like quite far from having models that learn on the job in like live clinical practice, but it'll be interesting to see the future of iCAIRD and the SHAPE platform and whether we can simulate situations like that and continue to kind of have that conversation with the regulators such that they're confident with that as well. But at the moment, it's very much a kind of build model, freeze model, regulate model, deploy pipeline.
That's great. Thank you, Dee. We have another question on the chat, if I just read that out for you. And this is from Lucy Normington. How long do you think that the technology is going to take to be implemented into NHS or into clinical practice? And what do you think the barriers are to this?
Very good question. And we did a survey about a year and a half ago, presented at the UK National Congress, and it was about radiologists' opinion, breast radiologists. When do you see this coming? 0 to 1 years, 1 to 3 years, 3 to 5 years, 5 to 10, and never ever, it's all hype. And the consensus was more in the 3 to 10 year period. But the reality is that, as you can see with the pandemic, we've all gone online. Technology has moved on. We're using Amazon Web Services, software, cloud work as well. And I think that we have good potential with the recent AAC, Advanced Access Collaborative Awards, and the current NIHR, National Institute of Health Research Phase 2 awards that we are looking to bid for, where we can move into the next stage of Phase 3, as they call it, which is just a test environment. Scotland is unique because we are ahead of England in this sense. We have a paperless digital breast screening system. So we're already integrated and we're already working in a paperless environment, just clicking opinions, whereas our colleagues in a lot of centers in England are still ticking paper sheets for their opinions when they read a mammogram. So we have a head start in that sense, and we should parlay that in that we have a training module where we can integrate an AI into that training module to do reads on ladies without affecting the final opinion. And we can assess those reads prospectively. So if you're wanting a complete answer, I would say from here, 1 to 3 years, if everything aligns nicely, because the data from Scotland will inform English and Public Health England opinions and the National Screening Council, which is the overall sort of area, as well as Scottish Government Public Health Directorate. So you've got to get hearts and minds into it. You've got to get the evidence as well. And you can't get too wrapped up in the excitement. You've got to get the proof. And that's our job today. The Phase 2 retrospective work that we've done in Aberdeen and the Phase 3 work that we want to continue on with Chiron and partners to move forward to test this prospectively in real life.
That's great. Thank you, Gerald. And I think you highlighted there some of the potential barriers to implementing this. And so there are barriers in relation to getting approvals to have this working. And it's important that there is very strong evidence to demonstrate that not only is this sensitive and specific and that it works appropriately, but also that it is financially feasible as well with it being integrated into the service. Has anybody else got any other questions? I have a question maybe that Dee could comment on, just in relation to the sensitivity and specificity of the MIA model at present from the research that's already been undertaken.
Sure, happy to. So we see this is when I'm talking about independent reader is when we're optimizing for that highest sensitivity with highest specificity point. And we see that we're pretty comparable to the human readers at that point. So top of my head, Gerald, you'll correct me, but that'll be like high 80s, low 90s sensitivity specificity for a first human reader. Second human reader is interesting, and Gerald, you can add more on this, because often they're not blinded to what first human reader has said. So that means their sensitivity is much higher. But yeah, also the really cool results that you see are when you do the combined, you look at double reader performance and human reader 1 plus MIA, because it's that combination that looks cool. But you'll have to disseminate our research for the hard numbers, because that's top of head. And also, Leslie, I looked, it was 34 hours for 26,000 cases, given the compute constraints that the setup had. So there's a little taster for you on speed.
That's fantastic. Gerald, do you want to just highlight as well about the sensitivity specificity of the current system? And one of the things that I think is really interesting in the breast cancer screening world is the interval cancers as well. Could you have a bit of a discussion around that?
Of course, yeah. We expect readers to be calling back between 5 to 7% as a recall rate, and the cancer detection rate should be in the region of 7 to 9 per thousand as an individual. And because it's all paperless and digital, this is already being measured through reports that come through and are seen by monitoring and evaluation groups of the Q quality assurance team. What Clarisse has done really well, and in our first paper submitted from iCAIRD, is how reader pairs work. So two readers who are reading together can, if they agree too much together, the cancer detection rate goes down. And if they disagree too much together, their cancer detection rate also goes down. There is an optimum point where two readers who disagree are actually divine in that they pick up a lot more cancers. So the optimum combination of two readers can bring your cancer detection rate from 8 in 1,000 up to 12 in 1,000 or 14 in 1,000 in actually in very good pairings. And that's one of our research angles that we're going to be looking at when we look at the retrospective, how MIA working independently and blinded to our opinions, and we working as a blind first reader, how many more cancers can we get? Because we're seeing that MIA is not competition, and taking people's jobs, but MIA is enhancing us to make us better and pick up more cancers, because that's the name of the game and that's the job that we are in to do this. Did I lose my train of thought?
I would just add to that, Gerald, that you as first or second reader can also pull up the prior screening images from the lady's previous appointments. I think you mentioned it in one of your cases, and you can see the change over time. So if there's something that looks a bit odd, but actually it was there 3 years ago, I mean, you're the breast radiologist, but maybe that would make you feel more comfortable that it wasn't anything kind of to be worried about. But at the moment, we haven't incorporated the priors to MIA's training, only kind of training on the images themselves. So that's kind of an unfair advantage on the humans, really, but also that's a really interesting kind of research avenue for us of, is it possible to incorporate the priors per case? And then would we see that jump in performance as you would expect with humans as well?
Absolutely, Dee. I think that's a really interesting research angle, looking to see whether utilization of prior images can enhance the ability for the AI platform to detect whether or not it is likely to be a cancer. So I think that would definitely be something of interest. Gerald, I'd asked just about interval cancers. That was the other question.
So interval cancers, because we screen ladies in a 3-year round, it does take a long time before we get back to ladies. And in the interim, if there's a cancer that is missed that comes to the symptomatic clinic, that's what's called an interval cancer. So a cancer that is in between screening rounds. And you would expect that in any program, because cancers do have to develop sometime and somewhere. And you would probably get 20 to 30 interval cancers a year in our program here. We get 200 cancers a year, so about 10% of interval cancers a year are expected. And one of the keys is sometimes whether that's just a missed cancer, that even two people reading have missed that, or whether that is a true interval cancer, whether it's just grown in that time. And we're looking at AI in that sense, whether it has any sort of predictive ability, whether it could pick up some of these interval cancers. And that forms part of our retrospective research. We'll wait and see. Even when we look in retrospect at some of these cancers, they're really subtle. And some of us may have called it, some of us may have not called it back. But that's the beauty of having two readers, because the two readers have different experiences and different. So I may not be very good at a certain thing, but my other colleague calls a lot of those things. The two of us reading together become better and pick up more cancers. And I think that has a role in interval cancer, pick up a reduction of the interval cancer rate as well. And we'll see how that works with the AI combinations with the humans as well.
Fantastic. Lots of really, really fascinating stuff here. Has anybody else got any other questions? I feel as if I'm hogging all the questions because I just find it such an exciting area. But if we don't have any other questions, I just want to take this opportunity to thank all three of you for giving your time today to come and present at today's meeting. It's been a really fascinating exercise to hear from each of you. And I'm sure Rachel as well will come in at the end just to thank everybody for attending the meeting. We have over 20 participants today in the call, and I'm sure we'll have many more viewing online. And I just have from Maura here, just echoing earlier observation that it's an excellent example of effective teamwork and collaboration across so many different partner organisations, and a real success story so far. And it'll be really interesting moving forward and looking at how to integrate this into clinical practice moving forward. So Rachel, I don't know if you have any other comments you want to make?
Yeah, thanks very much, Leslie. Just to say thank you to the audience for attending. Hopefully you found today's session interesting. We do have a feedback survey that's on your screen now. It's got a QR code that takes you direct to the survey. It would be fantastic if you completed that survey. It helps us improve our events for the future. And I'll also email out a link to the feedback survey via email after today's event. I'd like to thank the presenters, and I'd also like to thank the media services, CPD services and events team that have supported today's event and helped me with the smooth run-in. And again, thank you to the audience for attending. We do have 60 events taking place across Scotland as part of Explorathon this week. So if you do want to find out about the other events and the other interesting talks, presentations, debates, tours that are happening all online this week, you can go to the website, and that's at www.explorathon.co.uk. But wish you all a great evening and afternoon, and thank you for coming.
Thank you, Rachel.
Thank you. Bye-bye.
Thanks, bye.
Appreciate it. Thanks, bye.
Thank you.